Welcome to this presentation on communication. Clearly, communication in assisted living is absolutely the key to helping improve resident care, to helping improve the continuum of care, and helping make sure that we improve continuity of care throughout the system. So, what is your communication pattern? The flow of communication impacts the quality of the work being done here at Dayspring Village. Your communication pattern is something that really will drive access to care. It will drive the treatment planning process, the service planning process. It will have a broad impact on so many aspects of the care that's provided at Dayspring Village. So the question for you is to examine closely and look at what is my pattern of communication? What is it that I do that helps facilitate communication and ensures that information is flowing to the right people at the right time and in the right format? So let's look at what information do you communicate. So we have medication issues, there's changes in behavior, residents may need an appointment for something. Adding a resident to the agenda for a case management meeting is always an important task. Elopement behaviors or risks, if there's evidence of elopement in the resident's record, or if we have active incidents or circumstances where somebody has left the facility in a manner that is not consistent with our policy, then that could potentially be an elopement. Drug-seeking behavior or failed drug tests are also issues that need to be communicated. We do substance abuse groups here on site, gives us an opportunity to collect information. When you do interviews, you can collect information when you observe residents in the med line or even in the meal line. Gives you an opportunity to collect observations and information based on what residents state to you or what their peers communicate. Communication is flowing all around you. It's flowing from residents to staff, staff to case managers to doctors, and the facility manager is coordinating all of these issues at the same time. So let's have a look at what must you communicate for successful care, because that's what we're all really interested in. That's what helps our residents be successful and ultimately helps each of us professionally to become successful caregivers. So you've got to have documentation of assistance with medication. We provide supervision of self-administration of medication here at Dayspring Village. So it's really important to make sure that you're observing the resident, making sure that they take the medication, and also you have to make sure that you read aloud the medication in the presence of the resident at the time that they are at your med counter. You need to maintain privacy, auditory privacy, so that the resident is out of range, so that they have privacy when it's being assisted with their medications. We also provide assistance with ADLs. So what does ADL stand for? Activities of daily living. So no question, we also provide assistance with IADLs, such as laundry, shopping, money management, room cleaning, clutter management, and of course, ADLs, activities of daily living, include personal care services such as shaving and bathing and showering, helping people with clothing issues and things of that nature. We also need to communicate elopement and adverse incidents. So elopement is very clearly outlined in our policy. That's the subject of another training that we often do. And adverse incidents are required. So if the facility had control of the circumstances and if the incident resulted in a range of other activities, and we'll do a training and a presentation on adverse incident reporting, but that is something that we're always looking at and making sure that we meet that one-day reporting requirement if in fact it is an adverse incident. Details that lead up to a request for the Baker Act. This is a requirement that is in the rules, so it's very important that when you're moving towards a Baker Act situation that you are recording the circumstances or the facts that lead up to the request for the Baker Act. So the rule's very specific about that, and we need to make sure we're compliant. And also, what did you do to try to obtain the resident's medication? So a lot of times there can be issues with medications. The pharmacy may have run out. There may be a national shortage. You could have a health plan deciding, look, they can't pay for it. They can't pay the copayment. And so there's lots of things that are affecting medication management today. But the key thing for you as a direct caregiver is, what did you do to try to obtain it? Did you send a secure message to the pharmacy? Did you send a secure message to the medication coordinator? Did you contact the case manager? Did you contact the doctor and say, hey, look, we don't have a refill, we need a refill? So there's a number of things that you can do, that you should do, to try to obtain the medication, and you need to document or communicate that to the resident record in Point Click Care's progress note section. So let's talk about what is a significant change in condition. Because this oftentimes is the trigger. If there's a significant change in condition, this will trigger that you need to document about that person's circumstances or what you observe. So let's go through the definition. It means either a sudden or major shift in behavior or mood of the resident that is inconsistent with the resident's diagnosis, or a deterioration in the resident's health status, such as unplanned weight loss, stroke, heart condition, enrollment in hospice, or a stage 2, 3, or 4 pressure sore. Ordinary day-to-day fluctuations in the resident's functioning and behavior, short-term illnesses such as colds, or gradual deterioration in residents' ability to carry out activities of daily living that accompanies the aging process are not considered significant changes. So a significant change that would be inconsistent with the diagnosis is something where somebody is no longer presenting as what we call baseline behavior. Baseline behavior would not be considered a change in condition, but if something new appears and you start to see new symptoms, both physical symptoms or psychiatric symptoms, or things just don't seem right, that's when you need to be paying attention. Is this a significant change in condition? And we need to follow the protocol and document, and making sure that we're updating the record to reflect that change in condition. So in the assisted living facility, you have a lot of third-party providers that come to Dayspring Village to provide a whole range of services. Sometimes those are physical therapy services, sometimes it's home health services, sometimes it's mental health services or individual therapy services. And we need to make sure that we are documenting what third-party providers do. The rule is very clear about that we have to have that coordination, that communication, and making sure that they are providing that feedback to us about what it is that they were doing and what is it that is happening with the resident. And so there has to be that close coordination between you and the third-party providers. And so you have to document into Point Click Care that third-party provider was there today to see whichever resident, and making sure that that's included in the progress notes so people can see and understand the third-party provider was on campus today, they did provide a service, and they have to, importantly, sign into our logbook, our logbook, and they have to sign out. So they need to make sure that we get the date and time that they signed in, date and time that they signed out. So again, that's another part of communication. It's very important that we're communicating with third-party providers. One of the things that we do with our mental health providers is we have weekly meetings, both with Northwest Behavioral Health, Starting Point. We also meet regularly with the other mental health providers in making sure that there's good coordination around the information related to our residents. So here's the requirements for third-party providers. It means any individual or business entity providing services to residents in the facility that is not staff of the facility. So the resident may contract with a third-party provider. Third-party provider must coordinate with the facility regarding the resident's condition and services being provided. The administrator or designee must allow the resident to receive third-party services if resident meets criteria for continued residency. And that's a decision that is made during our staffings. It's a collaborative process that we work with our healthcare providers, the case management team. It's a collaborative process, and that's why communication is so important. It has to flow in all directions. The facility assistant does not guarantee that third-party services will be received. If a resident refuses efforts or are unsuccessfully, the facility must document in the resident's record explaining why efforts were unsuccessful. So What this means is that if you attempt to make a linkage to a third-party provider service, and let's say it's home health service is a good one, or occupational therapy or physical therapy, and you're unsuccessful in getting that link done, then you need to document that. That's a communication requirement that's in the rule, that you need to document why it was unsuccessful and what it is you did to link it. Just because you're trying to assist them accessing services doesn't provide a guarantee that they will access that service. But you, at the same time, you have to document what it is that happened, that linkage was unsuccessful. So let's talk a little bit about what steps do I follow. So we're going to document a request for third-party services in PCC progress notes. You need to send a secure message over to Taylor Flora and ask that this unmet need be placed on the case management agenda. There will be a discussion to discuss the unmet need at the weekly care coordination meeting with facility manager Colleen Reardon. There's no question that that is an important part of the flow. Document when the resident is receiving third-party services and make sure we have notes about your efforts to coordinate resident care with the provider. And so sometimes you'll have providers that, they don't want to talk to you or communicate or provide the kind of collaboration maybe you would expect. You really need to make sure that you're documenting that and that your efforts to obtain the information and what was said. So whatever was said, just write it down, quote unquote, here's what they stated. Document and explain in the resident record if the third-party service is requested and you're unsuccessful in obtaining. And again, like we talked about before, Medicaid, or if it's transportation, before somebody's benefits are being restored, any types of those services, if you're attempting to link that service and you're unsuccessful, make sure that you document in the resident's progress notes so that everybody will know and communication continues to flow. So let's talk a little bit about elopement documentation. This is really important. So residents assessed for elopement is under the 58A5 rule .0182. All residents assessed at risk for elopement or with any history of elopement must be identified so staff can be alerted to their needs for support and supervision. All residents must be assessed for a risk of elopement by a healthcare provider, mental health provider within 30 days of being admitted to the facility. If the resident has had a health assessment performed prior to admission pursuant to this paragraph, this requirement is satisfied. That's one of the reasons we ask for the health assessment before the resident gets to the facility in order to meet this need. Now, a resident placed on an emergency temporary basis by the Department of Children and Family is exempt from this requirement for a period of time. Now, it is important that you understand that with elopement, we have a lanyard that we'll be using, and those lanyards will include the facility name, the address, the telephone number, and then you will take a Sharpie pen and write on the inside of the lanyard the name of the resident, and that will meet the requirements for ensuring that they have documentation as to who they are and where they are, and it's a good way of identifying them. So we're going to talk a little bit more about elopement later. So here we are, elopement documentation. As part of the elopement response policies and procedures, the facility must make a minimum, a daily effort to determine that an at-risk resident have identification on their persons. This includes the name, their name of facility, address, and telephone number. Staff or trained person must generally be aware of location of all residents assessed at high risk of elopement at all times. So this is one of the reasons we do the documentation into the resident record every 3 to 4 hours on somebody that we've assessed as being at high risk. Not everybody's going to be assessed at that definition of high risk, but in an abundance of caution, what we will be doing is making sure that these lanyards are available, and the lanyards will be an effort or opportunity for us to make sure that residents who need this sort of identification, need this sort of support, will have these lanyards available to wear with them during the day, and this will help meet the requirement. So it's very, very important that you understand who is at high risk and who is not. Most residents are not at risk of elopement at Dayspring Village, primarily because of their psychiatric condition, but from time to time this does arise, and we need to know how we will respond and why we're doing the things that we're doing. So medication practices are found on Florida Administrative Code 58A5.0185. And one of the things that's really important for you to pay attention to, and again, this all relates back to communication in our practice or our pattern as to how we communicate, is the facility must contact the resident's healthcare provider when observable health changes occur that are attributed to the resident's medication. The facility must document such contacts in the resident's record. So when you do a secure message, and let's say you're doing a secure message to the starting point provider, Alex Johnson, or let's say you're sending it over to Dr. Lepoli, you need to make sure that you've documented into the progress note that that has happened. Now, one of the things you can do with secure messaging in point-click care is you can convert that secure message to a progress note. There is a functionality for that. You just simply need to ask the facility manager or one of the resident care coordinators to help you with that. And I think you'll find that makes it an easy way to document when you observe changes that are attributed to the resident's medication, and that information is getting to the healthcare provider. So let's ask these questions. Does the rule require staff to document conversations with the healthcare provider? Answer would be yes. In certain cases, that's absolutely true. When do you call the healthcare provider? Well, it seems to me that when you have a significant change in condition, you have to call, but also when you observe observable health changes that may be attributed to the resident's medication, you need to call. And how would you document or meet this standard of practice? Well, again, it's all about your communication pattern. It's all about your professional standards and your practice. And so building your practice, you need to get into the rhythm of using the secure messaging tools that are available to you, document the change or observable condition that you noted, and then convert that to a progress note, and you're done. We've tried to make it very easy for everybody, but it takes you to adhere to your own standard of practice and making sure that you're following these guidelines. So we're still on medication practices, and this is really important. So pill organizers is something that you're seeing a lot of in assisted living facilities today. So unlicensed staff cannot provide assistance with the contents of a pill organizer. It's very important that you cannot pour medications from the container and put it into these pill organizers. Only a nurse may manage the nurse may manage the pill organizers only for residents who self-administer the medication. Pill organizers must be labeled with the resident's name, must document the date and the time the pill organizer was filled in the resident's record. So you need to put in a progress note, date and time that the pill organizer was filled into the resident record. If the pill organizer is filled properly, then staff may make this available to the resident's family or friend upon leaving the facility. This fact must be noted in the resident's medication record. So here we see above, you simply need to document in the resident's record, which would be a progress note. And then right below that, what we see is if you have made this available to the resident, the family or friend upon leaving the facility, the pill organizer, you have to document a note in the resident's medication record. So it's very important because these are, again, are all communication mandates or requirements that are placed upon the staff, and it's important that you build these into your practice, because when you build this into your practice, then your practice then becomes compliant with state standards. So medication documentation continues to be an important issue. So for medications that serve as chemical restraints, the facility must, pursuant to 429.41, maintain a record of the prescribing physician's annual evaluation and use of the medication. So in an assisted living facility with a limited mental health license, most people have a psychiatric condition. And so the prescription for the psychotic medication is generally not used as a chemical restraint. It's used to treat the symptoms associated with their psychiatric condition. Now, and let's say in a senior living facility, the use of psychotropic medication, in fact, could be considered to be used as a chemical restraint, in which case this section would require you to do what? You would have to maintain a record of the prescribing physician's annual evaluation and use of that medication. So, how often should the medication and its use be evaluated by the doctor? Yes, the correct answer is annually. How would this evaluation take place? Well, the doctor is going to have regular scheduled appointments with the resident, preferably anywhere from 1 month to 3 months. Sometimes the doctor sees the patient more frequently than that, but at minimum, on an annual basis, if the medication is used as a chemical restraint, then it would need to be documented and its use documented on an annual basis. Can you think of what medications would be used as a chemical restraint? This is a very good question. We have a whole lot of the medications we use at Dayspring Village in other settings could be considered chemical restraints. And if medications are used in a higher dosing levels, those also could be considered chemical restraints. So it's very important to understand what the proper use of the medication is and why the medication is being prescribed. So let's talk a little bit about over-the-counter medications. This is a new change in the ALF rule in Florida. So a facility can maintain a stock supply. We have an orange box in the medication room that has stock OTC medications in it. Now the staff must record the name and the amount given in the medication observation record. We typically will want you to contact the doctor to discuss with them, and certainly once we receive approval, then we can proceed forward with the medication. All OTC stock supplies must have a date of purchase on them. All OTC stock supplies must be labeled DSV stock supply. Has to be clearly labeled. Prescribed OTC meds must have the resident's name and directions for their use. So that if somebody's prescribed an over-the-counter medication, it's in their med box, then you must make sure that those requirements are being met. A licensed nurse must have a healthcare provider's order before making available those OTC medications. So it's very, very important to understand a non-licensed person can certainly provide assistance with medication and including these OTC medications absent the doctor's order. But if you're a licensed nurse, it's a little bit more strict. The licensed nurse must have a doctor's order prior to providing that OTC medication. So let's talk a little bit about DNRO and documentation. So do not resuscitate orders is a very important issue. The facility will provide on admission a copy of the healthcare directives and do not resuscitate orders. So on admission, in our admission packet, those documents are made available. The staff must document into the resident's progress notes whether the DH 1896 was executed or not. While the signed forms are scanned in, it is good practice to write a progress note into the resident's record. So while we know that those documents are scanned into our system, it's also good practice out of an abundance of caution to identify in the resident's record that a DNRO has not been executed in this case, or if it has been executed, to identify that so your colleagues, as they go through their 24-hour report or 72-hour report when they come on shift, can clearly see this is who's got a DNRO here at the facility. Hospice procedures will always take precedent over those of the ALF if a hospice patient experiences a cardiac or pulmonary arrest. So again, that's one of the reasons we coordinate closely with hospice, and we have to have an interdisciplinary plan in place when we're dealing with them. We must have DNRO training within 30 days of employment on our policies and procedures. So it's really important that you pay attention to our DNRO policies and procedures within the first 30 days of your employment here at Dayspring Village. So again, it's also important to communicate about special diets and weights. It's a really important resident record type issue. And so documentation of a resident's refusal of a therapeutic diet, it has to be documented in the resident record. The weight record that is initiated on admission. So the day that the resident gets there, you have to ensure that the weight's recorded into point-click care. This is really important. The information may be taken from the ACA Form 1823 or Resident's Health Assessment. Residents receiving assistance with ADLs must have the weight taken every 6 months. We normally will do this monthly or if not weekly if we're concerned about weight loss. So documenting special diets or refusal to follow special diets or observations that they're not following the special diets is important. Also making sure that you are monitoring the weight monthly, and also making sure that weights on admission are being recorded into the resident record. So documentation of the healthcare surrogate, power of attorneys or guardians is also important as well. So the facility must have a copy of the documentation needed to confirm the legal authority of the POA, healthcare surrogate, or legal guardian. A lot of times people believe that if I am the payee representative, that somehow makes me the legal representative or POA, or is a grant of legal authority that otherwise does not exist. We have to see the POA, healthcare surrogate, or legal guardian papers in order to evaluate them to establish who has that authority. You would normally send a secure message to Taylor and request the missing documentation issue be placed on agenda for discussion at the next case management meeting. So here are the questions. Do you believe the residents who need a do you believe you have residents who need a POA or legal guardian? You need to send a secure message to Taylor Flora and ask that the issue of legal capacity be addressed at the next case management meeting for that resident. So communication is not just limited to documentation requirements. We also have limited mental health documentation requirements. And so there's a lot of discussion about who is a mental health resident in a limited mental health ALF. Well, there's a very special definition, and that definition is essentially a person who receives Social Security due to a psychiatric disorder and receives optional state supplementation. So they have to have both. So in this case, would a person who receives SSI due to a psychiatric disorder but has not yet received optional state supplementation qualify and be considered an OSS resident? Well, you know, the statute says they have to have both in order to meet that definition. And so documentation provided by the mental health care provider within 30 days of admission that the resident meets the definition of a mental health resident. So they can meet this standard within that 30 days with a signed alternative care agreement 1006 form, written verification from Social Security the person receives benefits due to a psychiatric disorder, or a written statement from the resident's case manager or other mental health provider that the resident is an adult with severe and persistent mental illness. There's a number of ways to comply with this requirement, but again, this requirement has to be met within 30 days of admission to the facility. So we're still looking at limited mental health, part 2. The documentation requirements can be met with a discharge statement from a state hospital that is 90 days within admission. So if the person just got out of the state hospital and you have a discharge statement, that can meet the requirements. Other signed statement that the resident has been assessed and found to be appropriate to live in the assisted living facility. So that could be a statement from the doctor indicating they're appropriate to live there. Each resident who is defined as a mental health resident must have a community living support plan prepared by their case manager in conjunction with the resident and the facility administrator or designee. If the resident refused to sign, you must add a statement the resident refused to sign the plan. There must be a cooperative agreement that can be combined with the community living support plan. The agreement must provide directions on how to access services after hours and provide access to emergent 24-hour emergency response line. Each mental health provider that works with our residents must have that capability in order to respond to the resident in a psychiatric emergency. So I get this question a lot, what to do about missing documentation. So the administrator must, within 72 hours of admission, make the request for missing documentation to the Medicaid health plan or the managing entity to be compliant. That's a pretty tight time frame. But on admission, that is a good thing to do, is to make sure that that request for information goes out. The request must include the name, the title, the phone number of the person to whom the request was made and is kept on file. So in each of the resident files, we need to make sure that we're sending out this request for this documentation, community living support plans, and other missing documentation within 72 hours, and the facility will be declared or determined to be compliant. But you have to include the name, title, phone number of the person to whom the request is being made. So communication practices are also very important in terms of the Baker Act, and the Baker Act is a very important part of the process when somebody doesn't have capacity to determine whether or not a mental health evaluation is necessary. So, but what the rule says about Baker Acts in assisted living facilities is this. If the facility initiates an involuntary mental health examination pursuant to 394.463, the facility must document circumstances leading up to the initiation of the examination. Staff must document the events that unfolded prior to calling law enforcement or requesting a professional certificate. Make sure somebody is focusing on getting the notes. This is why your spiral notebooks and your notepads and your documentation in real time becomes very important. You got to put down the date, the time, the name, and as things are unfolding, you can just simply jot down quick notes. It allows you to go back in time on point-click care, so you can select the exact time this happened, the date it happened, and put your notes in and make sure that we're being compliant with documentation of what was leading up to the circumstances that resulted in the Baker Act. And again, it's very important for you to know that the facility does have a right to initiate or to request the involuntary mental health examination. It doesn't guarantee that the officer will determine that the patient or the resident meets the criteria. And a lot of times what we'll try to do is seek or pursue, if the resident's appropriate, making sure that they get the mental health evaluation they need in the least restrictive manner. So let's talk a little bit about documentation of behavioral health changes. Make sure that you keep pace with your resident interviews. You need to have, there should be a list of interviews that were assigned to you. This will surface important details that may suggest the need for professional mental health services. Be sure to document your work in point-click care so we can track what is happening and when it's happening. It's best to use the tablets to make this happen faster. This frees up more time for direct resident care. If the community living support plan needs to be updated or amended, please ask Taylor Flora to add this person to the agenda for the next case management meeting. That ability to put things on the agenda for the next case management meeting is incredibly helpful to the case managers. I know it's incredibly helpful to the facility manager. And when you request an evaluation from Starting Point or Northwest Behavioral Health, be sure to document your efforts and what happened as a result of the evaluation into PCC progress notes. Your documentation, again, that's critical communication, critical flow of communication. It is really important part of building your practice and helping achieve a higher standard of continuity of care. If the resident requests to see their psychiatrist, make sure you send a secure message so that person can be added to the list to be seen. And so it's very important that you send those secure messages over. Make sure you copy the nurse and make sure that you also add the facility manager and myself to this, because it's really important everybody knows this resident wants to see their doctor, and we need to go ahead and get that link done as soon as possible. So communication flow happens because there is good documentation. So clearly at the end of the day, when we think about communication in assisted living facilities, we think about documentation. So you have notepads, spiral notebooks. We will provide you with whatever pad that works best for you. I want to make sure that you have one because this is how you grab the source data. Be sure to write when others talk. It communicates a very powerful listening message. When somebody sees you writing down what they're saying, they really truly believe that you are listening to them. Use your written notes to create your electronic progress notes and POC data. It's mandatory for each member of the client management team to produce 4 progress notes per shift. We simply want to know that you have seen 4 residents at the campus today during your 8-hour shift, and you had something meaningful to say about them. And this is how you build relationships. It's only when you're interacting with residents, spending time with them, getting to know what their baseline level of functioning is, that you can start to build trust and build a relationship with them, so that when they do happen to fall into a crisis, you will be the key person helping there to help them get through the crisis safely, and making sure that we get the services connected to them that they need to get their medications restabilized. So let's look at all the communication platforms that are around you. Point-click care is a massive communication platform. There's a lot of things happening on point-click care. You have the communications tab. You can post notes before everybody goes to their 24-hour report or 72-hour report. You have progress notes. Everybody can see what's been happening or what you've been documenting on. You have secure messaging. You can include a lot of people. All you have to do to get all your colleagues in the MedTech group is type in the words MedTech or medication technician, and up it will pop, and everybody will be copied on the same information you want them to know about. The bulletin board is also an important communication platform. We don't typically put resident type information on there because of privacy concerns, but we do want to make sure that you are looking at the bulletin board. It has lots of information about standard of care protocols, who's at work today, who's not at work. It'll also give you information about policies or special events. Resident engagement activities are identified there, and that's where we will identify things that are happening in the facility. Resident schedules and calendars are also important. Making sure that things are documented into the resident schedule and calendars is another area inside the point-click care platform that is critical to you. There are weekly care coordination meetings. You need to attend these. This is a great opportunity for you to have input into the process and for you to hear back from the facility manager. There are bi-weekly staff development meetings that are important to attend. And also we have weekly meetings with the case managers and providers to ensure that there's good coordination with these third-party providers. So you are the front line for communication. Without you, none of this communication is possible. None of this information flows correctly, and there are big gaps within the continuum of care. So it's really important that we work on helping you build your practice, build your skill sets in the area of communication in order to ensure that we are meeting the requirements and that our communication platform is adherent to the rule in terms of what is required. There's lots of deadlines. There's lots of nuances to all of this. So I know that it can be complicated. But again, communication is essential. It's the key to continuity care. It's the key to helping these the residents that we serve become successful in managing the symptoms of their mental illness. Thank you for all that you do. I look forward to answering any questions you have. We appreciate your hard work and your dedication. And if you have any questions, please feel free to come to myself or the facility manager in order to get those addressed. Thank you so much. Bye now.